Welcome to the American Shoulder and Elbow Surgeons Podcast. I'm your new co-host, Brian Waterman, a sports and shoulder elbow surgeon at Wake Forest University in association with Atrium Health. I'm fortunate to have Peter Chalmers, a shoulder and elbow surgeon at the University of Utah in Salt Lake City, as my co-host. Welcome, Pete.
Well, I'm so excited to be here and for us to do this today.
So before we get started, I should mention that the views expressed in this podcast do not necessarily reflect the views of the American Shoulder and Elbow Surgeons Society, the University of Utah, the Wake Forest University, or the institutions of any of our guests. Okay, so it gives us great honor to welcome our distinguished guest to the podcast, Dr. Dean Taylor. For many of us, he's someone that will need no introduction. Dr. Taylor is currently serving his term as AOSSM president. He's professor in orthopedic surgery at Duke University, fellowship director in sports medicine, and chair of the Fagan Leadership Forum. His accolades are far too numerous to recount, but highlights include the George D. Revere Award from AOSSM, the Brian Allgood Memorial Leadership Award from SOMOS, and the O'Donoghue, Houston, and Aircast Awards from AJSM. On top of that, he's a decorated military veteran of 24 years, and he's a proud family man. So, Dean, welcome to the podcast.
Thanks. Great to be here, Brian and Peter. Appreciate you guys inviting me.
Well, it's truly our honor. I think we're all recouping from jet lag after coming back from San Francisco and the AAOS annual meeting. And during that, we celebrated the Combined Specialty Day program with you and Peter McDonald from the ASES. Perhaps we can lead off with some of your takeaways from the combined meeting.
Well, thanks. And I'm still energized by my week in San Francisco because it was a week of great collaboration and a great look to the future. And one of the things that I'm emphasizing in my presidential year for AOSSM is collaboration and leading collaboration. And I think the Combined Specialty Day that we had last Friday was a great example of what we can do together with other societies. And ASES and AOSSM combined for an amazing program. First, separate, each organization highlighting some things that were specific to their organization, and then coming together for an amazing session on shoulder instability. The Kennedy lecture by Bob Arciero was an exceptional treatise on shoulder instability from stoop to nuts, and was just fantastic. And for your listeners, if you weren't there, I'd highly recommend you seeing whatever recording is going to come out of ASES and AOSSM, because it's a fabulous talk. And then we finished it off with an amazing session on rotator cuff. So I couldn't be more happy with how that went, and it was a great and fitting end to a super week in San Francisco.
Yeah, I would just commend your program chairs, both on the AOSSM and ASES side. Really was a fantastic program, and I'll call them out by name. John Dickens, Allison Toth on the AOSSM side, and Jared Woodmass, Chris Clifto, and Eric Wagner. It was great content. A lot of Duke representation there too, Dean.
Dickens and Toth are our program chairs, and somehow ASES slipped Clifto in there. So we had some Duke Blue influencing how things went. So I think it was a good reflection on Duke.
Yeah, and Tobacco Road in general. Yep. Well, we certainly know you to be a dedicated shoulder enthusiast, particularly as it relates to shoulder instability. I would imagine that much of this is spun out of your time in the military, particularly as a fellow and then former team physician at West Point. I'd love to go down memory lane and have you talk me through the early days of managing shoulder dislocations at the academy and how your approach has really evolved over time.
Sure. I feel very fortunate to have learned shoulder surgery in a very innovative and transformational time. I was a resident at Duke in the late 80s and finished residency in 91, and then ended up doing a 2-year fellowship in the military with a research year in San Francisco under Jack Ryan, who was a fellowship director of the research year, and then the clinical year the next year with Bob Arciero. And Jack Ryan, Bob Arciero, Jim Wheeler, Bill Hopkinson, they in the 80s recognized that with the development of arthroscopic shoulder surgery, that maybe they could do something about the high rates of recurrent shoulder instability that we would see in. So Jim Wheeler in particular was the one that started scoping shoulders after first-time dislocations. And then they published on their early work on that where there was some indication that early surgery may have some beneficial impact. And then Bob Arciero took it to the next level where he did a comparative study comparing transglenoid labral fixation, back of the scapula and tying sutures over the posterior fascia that fixed the labrum. That procedure before the onset of bioabsorbable tacks, before the onset of suture anchors and modern techniques, actually reversed the natural history of shoulder instability in that population from 80 to 90% recurrent instability to 10 to 20%. And then that really provided the foundation from which a lot of the other work is built. And I would say that as a fellow there, and then being an orthopedic surgeon from 95 to 2005, it was wonderful to see all that evolution. My little contribution to all that was working with Bob Arciero, where we looked at 63 consecutive first-time dislocators that underwent shoulder arthroscopy. Now, this was before we were getting MRIs on shoulders. So we looked at the pathologic anatomy of those 63 consecutive patients that had traumatic anterior shoulder dislocations that required a manual reduction. And we found that the pathologic anatomy was 97% of them had capsulolabral avulsion from the anterior inferior glenoid rim, a Bankart lesion. And so that, to me, that helped define what we were seeing. And by restoring that anatomy, we could reverse that natural history. And that was fun to be a part of, and then build off of that. And then and for a while, I think we were so much evangelists talking about you have to operate on the first time dislocator. You have to do this, and I think some mentors and some reflection and maybe opening up my perspective has helped me evolve into doing some research at Duke here with Chad Mather and with others to realize that, well, it's not an all or none, and we shouldn't be telling our patients what to do. We should come up with tools on how we can come to better decision making that individualizes the care for each patient, and shared decision making, I think, is an important piece of how we do that. And that's kind of been my evolution in shoulder instability, and to the point now where I think I look at myself as an educator as much as anything for patients, letting them know what the expected outcomes are with various treatment options, and then helping them decide what's going to be the best approach for their particular set of circumstances. And certainly operating on the first time dislocator in a high risk population is a piece of that. And I think it's been fun to see see that evolve over time and be a part of those that have contributed to that understanding.
Well, certainly that the evolution there is beautiful. I think I wanted to back up with you for a second. I mean, you underplayed very much the study you did at West Point, where you said my small contribution. I mean, I think that 63 patient study it's a huge landmark. It's a study that I teach to every single one of our residents when I try and teach them about shoulder instability. Tell me a little bit. I mean, when I read that study, it could not have been easy to do. Tell us a little bit, how did you conceive that study? How did you actually get it done? I mean, that's a landmark study. For many of our listeners, they're young in their career. You know, maybe they're close to where you were when you were starting to think about that kind of study. Tell us about what it took to really accomplish that.
Well, Peter, it's a team effort for all these things, right? It's not like I did it. We had a whole team that was working together, and that team at that point in time had evolved from Jim Wheeler, Jack Ryan, Bill Hopkinson, Bruce Wheeler, and Bob Arciero was the clinical lead there, and our partners there at that time and throughout, people like Joe Tenuta, people like Tom DiBerdino, Brad Nelson, and many others all contributed to this. So when I was fellowing on the faculty, they were working to capture as much information as they could about first-time anterior shoulder dislocations and actually all shoulder instability, and captured it at that time. Now remember, in the early 90s, we didn't even have email. Okay, so a lot of this is stubby pencil work, and documenting things on handwritten forms, and there's no EMR, there's no computer database, so it's capturing it and then sharing it amongst the team, and so my goal and my job was to kind of pull all that together, try and analyze what we're seeing, and then report that out in a way that was meaningful. And Bob was fantastic in really capturing the prospective data in that comparative study, and a lot of this information flowed from that into other patients too. So I think that the main lesson that I would say for your listeners is, emphasize that it's a team approach, emphasize that everybody contributes and everybody should be recognized for the successes, because it's not just one person. And if you do that, you can come up with some amazing contributions that move our field along.
Can I ask you one follow-up question about that study that I've always wondered?
Yeah.
So in the study, my read of the study is that 97% of the patients had labral tears. There's other interesting information, 10% of them had slap tears, also comment on the percentage with Hill sacks. And then there's one patient in the study with a habit. Is it true that the one patient with the capsular tear is the 3% that didn't have a Bankart tear, so that 100% had an injury to the capsulolabral complex at some point?
Yeah, in those traumatic dislocations in that population, that's first time dislocator, only one instability event. Yes, that's true. And so that one patient was the reason that we didn't have 100% Bankart lesions, because they had a haggle.
Because I've always thought that's like a really clear take home from that study, is that if your shoulder dislocates in a traumatic dislocation, there will be a capsular tear somewhere between the glenoid and the humerus, and you just have to find it. And when it's, there's so few things in life that are 100% like that.
Yeah, and I wouldn't say it's 100%. I mean, what we found was close to 100%. And we also had some patients that we didn't include that it had a shoulder instability event. Brett Owens and I wrote a paper with others kind of defining, we talk about subluxation. Well, what's luxation? Well, luxation is probably what we normally see, where there's a complete loss of reduction of the shoulder with spontaneous reduction. And so there's subluxation, there's luxation with spontaneous reduction, where we see the same pathologic changes we would see in a dislocation that's a fixed luxation, if you will, that then requires a manual reduction. And these all had a manual reduction. We excluded the ones that might have had a luxation with spontaneous reduction or a subluxation event, and some of those were patients that had a lot of laxity. And if we critically looked at those that had the spontaneous reduction with a lot of laxity, several of those did not have a labral tear. So it's a lot in the definition of what you call traumatic anterior shoulder dislocation. And for that population, we kept it as clean as possible, in that dislocation was one that required a manual reduction. Those that didn't may not have had the extent of pathologic changes that we saw, although Brett Owens and others have looked at the pathologic changes in subluxators, and they're pretty close to the same level of anterior inferior labral detachments from the glenoid.
Dean, I love the studies you mentioned, and I would say that you set the standard on being able to collect a lot of this epidemiological data, but also risk factors and rates of recurrence. And I think that is a unique attribute of the military system, in that it's a closed network. You have mandated follow-up, and you have basically 4 years in the incubator where you can really assess whether somebody sinks or swims. So I've always lauded the efforts coming out of West Point, because I think it really gives us an honest to goodness appraisal of how we're doing. And we need more of that, definitely, in the literature today.
Well, thanks, Brian. You feel when you're there, you kind of feel the responsibility to take advantage, not really take advantage, but really want to get the most out of that experience and the environment that you have. So I think many of us have built off of those who preceded us and wanted to understand better how we can know what the injuries are and best ways to treat them. And I think it is a good environment for that. And much of it is translatable to other populations, not all of it. I will say that in the military population, we get accused of having a patient population that will do whatever we tell them to do. I want to emphasize that that's not the case. In fact, when the 3 service academies did a study looking at postoperative bracing following ACL reconstruction, the one thing we found was that bracing didn't seem to matter on re-injury rates or outcomes. But to me, the most impressive thing that we found was that the cadets and midshipmen that were in the brace group were non-compliant about 30% of the time. So, and when people say that the military patients always do what you say, that ain't the case.
I've got several items that I can point to that support your premise. So for sure. I think you've helped to advance our understanding collectively of shoulder instability. And I would say what's old is now new again. You had Dr. Arciero as your Kennedy lecturer, and I think his message was loud and clear about how we should be managing these. I think, in your opinion, what do you think is the current role for the open Bankart in the current practice?
Yeah, it's I think it's one of the tools in the toolbox. And I think the more tools you have in your toolbox, the better off you're going to be in helping to address what particular problem your patient may have. And I'll take a step back here. So when I was a resident, I learned how to do an open bank card. And certainly when I was a fellow, we were starting to do arthroscopic procedures, but we were still doing a lot of open bank cards for recurrent instability. Um, I went through the transglenoid. I went through the sure tack bioabsorbable tacks that Dr. Warren and others were introducing, and then started with metal suture anchors, and then progressing to biocomposite suture anchors and a variety of others. But so I had learned how to do an open bank card. I still remember when Steve Burkhart and Joe DeBeer's article came out about bone loss. And they looked at the patients, rugby players primarily, that were in sport that had bone loss and had such a high recurrence rate that they recommended going, instead of an arthroscopic to a Latarjet procedure. Well, they jumped over the open bank card because the open bank card was a great operation, still is a great operation for restoring that anatomy. You can take some of the bone that may be off and reapproximate it along with the soft tissues. You can do a capsular shift, so that combined anatomy restoration of bone, labrum, and capsulorrhaphy, I think is a great operation that restores the anatomy. It doesn't distort the anatomy like a Latarjet. So in my mind, we have a lot of tools in our toolbox. For someone who's had one dislocation or maybe two or three with minimal Hill sacks, minimal bone loss. An arthroscopic bank card repair is great. If they have a Hill sacks lesion, maybe you add a remplissage. If they have more recurrences, an open bank card repair is a great operation, low recurrence rates, plenty of research showing that with good outcomes, patient-reported outcomes. If that fails, or if you have more bone loss and lots of recurrences, bipolar bone loss, then you have a variety of grafts, allografts, Latarjet. And for me, I've revised enough Latarjets in my time, and it's, as you guys know, it's not a pleasant experience. That for me, a Latarjet is more of a salvage procedure down the line. And I'd rather do an open bank card for that moderate amount of bone loss, and with larger amounts of bone loss, maybe a distal tibial allograft, and I'll do a fair amount of osteochondral grafting on the humeral side too, either with an arthroscopic repair and then a posterior approach, or complete dislocation and bone grafting on both sides for large bipolar problems.
Well, I think it's great to hear that. I'm sure that our European colleagues are all preparing to get up to the podium to tell you that the Latarjet is the only answer. But I agree with you that the open bank card has to play a role in our algorithm. And I think that there's probably going to be debate about exactly where it goes, but it should go somewhere, because certainly the evidence on it is pretty strong that it's a good operation with a low recurrence rate. I wanted to ask about something that you had in the middle of that sentence. You said, well, the person with the first time dislocation, and then the person with maybe 2 or 3 dislocations. So, you guys have done a lot of work to suggest that for high risk patients with first time dislocations, that we should offer those patients an operation because the risk for recurrence is real clear. Certainly, I've heard people in my own training say, well, you want to wait sometimes for those patients to declare themselves, have a second dislocation to show you that they really need the operation. So tell me how you manage that in your office. The patient comes in, they've had one dislocation. Many of those athletes think this was a freak thing. How do you counsel that patient about, you should consider having a surgery, or maybe we'll let it declare itself in dislocated skin, and maybe how does that reduce your likelihood of success?
Yeah, I think that's a great question, Peter. And there's we've worked a lot on trying to make that easier. It's still an educational exercise for each one of these cases. And the way I think about it is, one, the patient has to be adequately informed at what the expected outcomes are. So if you have a 16-year-old lacrosse player who wants to go back to playing collision sports, that's much different than someone who is a recreational athlete that's 25 that doesn't play collision sports, maybe plays golf or tennis or something along those lines. And I think that one, you have to have a good understanding of what the outcomes are. And when we've done studies looking at what well-trained shoulder surgeons believe the recurrence rates are for different parameters in their patients, about half the time they're 15 to 20% off. And so I don't think we adequately understand our literature, and we're not communicating that effectively to our patients in that regard. So coming up with tools like decision analysis modeling, and that's some of the work that we've done with Chad Mather here and Lori Orlando, where we can plug in demographic data and then build on that decision analysis model that helps patients understand, okay, if you're treated non-operatively, you have a 30% chance of having a stable shoulder 10 years. If you're treated operatively, it's 70%. That's just an example of the power of that. And then also understanding what's important for patients. And we've done some work, again, with this same group talking about conjoint analysis. What asking patients questions to get to what's important to them. And so when you share what's important to them and you share what the expected outcomes are, frequently they come to the decision on their own. And I think that's what we do in general, but those are long conversations. And when you're pressed for time and it's a challenge to get through your big clinic, that's not always easy. So we're still trying to evolve to that, where we use the power of technology to make it easier to come to that shared decision making. So for me, it's having those conversations, educating the patient, and then now we have even more information about, okay, what happens if you have 1, 2, 3, 4 recurrent dislocations? And John Dickens' work suggests that with each instability event, you knock off a little bit more of that glenoid. It's about 6% per instability event. So that's I think a meaningful piece of data that can be shared with the patient as they're trying to, as you both are trying to come up with the right answer. And if they're in the middle of the season, their senior season, they want to finish that season, they may be willing to accept some of those risks of recurrence, the risk of extending that labrum tear posteriorly, circumferentially. Bob Arciero in the Kennedy lecture, I think, showed a case where that was the case, and willing to accept maybe some bone loss too. So all those pieces are important, and for me, it's a challenge with everyone, some more than others, because you're trying to individualize it, and you can't make it an algorithm or a cookie cutter approach to all these things. If you're trying to get to the right answer or the best answer for that patient. And sometimes we don't know, and sometimes there's more than one right answer. And so that's the other piece of this, where sometimes we can become so dogmatic that we are focused on what we think is best. And I think our own educational offerings, you guys do this, you love those debates where one guy's like up on the podium arguing about his technique is best, and the other guy's arguing his, and you see it all the time, where they're making fun of each other, and it's great edutainment. But I think in the end, we have to understand that for a lot of us, don't know the right answer. Maybe there's 1, 2, 3, 4 good answers that could be applied. And until we have a clear understanding of what's best for each patient, having, like I said earlier, all those tools in the toolbox to apply it for each individual case, I think is what we should be thinking about.
Yeah, I think that lends a lot of texture to this discussion that I think we do. We tend to approach it in a very dogmatic way. Not to overplay the military card, but I would say we have definitely a whole host of leaders that have impacted me in this field. I'd put you among that, but Bob Arciero, Craig Battani, Walt Curl, a fellow Wake Forest connection, Tom DiBardino, Brett Owens, Matt Preventure, JT Tokish, John Dickens, and really so many more. But I would say that they all have a common connection, and that is John Fagan. I'd be remiss if I didn't offer you the opportunity to talk about how he impacted your career and was really the godfather for a lot of us that are working in this space.
Well, absolutely, and in many ways, I've been fortunate and lucky in my life to have been impacted by some amazing people, many of whom you've mentioned, and who I've been able to work with throughout the years. Walt Curl was my first orthopedic mentor. Gave me my interview for Duke Med School when I was a cadet, and that's how I got into med school. And at the time, I knew who John Fagan was. He was our hospital commander, but I never met him. He was the hospital commander at West Point when I was a cadet. And then I came to Duke Med School, where he had gone to med school. He was the first West Point grad to go to med school while on active duty. And he came to Duke. And everyone said, "Oh, you know John Fagan, right?" And no, I hadn't met him. But everyone you spoke to talked about this guy with such reverence. Then I did my internship in the Army. I did my internship at Fitzsimmons Army Medical Center in Denver. And everyone there knew John Fagan. And they said, "Oh, you know Fagan, you were at Duke." No, I'd never met him. And it wasn't until I was a general medical officer at Fort Leavenworth, and the guy I was working with, an orthopedic surgeon named Al Forbes, introduced me to John Fagan, that I met Dr. Fagan. And, Brian, you talk about what a special person John Fagan was. He made everybody feel like they were the most important person in the world. When you met him, and he was present, he was focused on you and knowing who you were. I had never met him. He was this legend, and I was finally going to get to meet him. And he gave a talk in Kansas City on the ACL, and people were lined up to talk with him afterwards. And after we waited our turn, and he gave Al Forbes a big hug, Al said, "Hey, Dr. Fagan, I want you to introduce our general medical officer at Fort Leavenworth, Dean Taylor." And before I could thank Dr. Fagan for everything that he'd done, he said, "I finally get to meet the famous Dean Taylor." And that's who he was. He was the guy that it wasn't about him. It was about making everybody else feel like they were special, and incredible network. And we we went on to become great friends, and I was lucky enough to be able to honor him in a couple ways. One, we renamed the Sports Medicine Fellowship at West Point the John Fagan Sports Medicine Fellowship, and secondly, we started the Fagan Leadership Program in his honor at Duke, and we got to work together with that, and we've impacted many medical students and residents and fellows that have been through that program, now over 300. And they're all a legacy to John Fagan's leadership. And I think you're right in saying that, John Fagan had a link to all those people in the military. I think he would also say that he had some pretty amazing people that he worked with too, that also contributed to that. And so it's a special group. And I appreciate you bringing it up.
Yes, certainly. You have a strong passion for leadership, and the Fagan Leadership Forum is a great homage to John Fagan and his legacy. Maybe I'd like to transition to that topic real quick and talk about why you think this type of training that you provide through your organization is so relevant in the current medical training environment today.
Yeah. Well, I thought I knew a little bit about leadership when I retired from the Army and before I came to Duke. And I did know a little bit, but I didn't know enough about what it meant to be an effective leader in healthcare until I started trying to teach that. And we started with our fellows and then expanded to medical students and residents. And I have come to learn that when we talk about leadership, it's not so much leadership that we want to talk about. It's how we work together with other people, and leadership has so many different definitions that sometimes that part of working with our fellow humans in ways that make healthcare better gets lost. And we're really talking about teaching skills that help people that want to be more effective leaders achieve that goal. And I think what I know now is that our definition of leadership is the ability to influence others for the benefit of patients and patient populations. And with that definition, everybody has a leadership role. And if we can teach skills that help people learn to be more effective leaders, we're going to make healthcare better. And so that's what we have focused on is really trying to teach skills that allow people to work with other people better. To be an effective leader in healthcare, it really requires two things. One, you have to be technically proficient, right? So all those things that you learn in med school, anatomy, physiology, pharmacology, all those things are important. All the things you learn in residency about how to do surgery. I mean, you can't be an effective leader in our profession unless you're good at those. The other piece of it is how do you interact with people, and that's those skills of emotional intelligence and teamwork and critical thinking and integrity and service. Those skills are the ones that we do not intentionally teach, and without the combination of the technical skills and the non-technical interpersonal skills, you have to have the combination of both of them. And without that, I don't think you can be as effective. I think it's a hard time. You have a hard time of influencing things for the betterment of even an individual patient, let alone patient populations. So what we teach are those non-technical skills, because I think they're underemphasized. They're not intentionally taught, and they're so important. There's of equal importance to the technical skills, but we don't teach or emphasize or provide the same amount of resources for them. And I think that's probably a reason why our profession is suffering. We need to have more physicians engaged in influencing what's going on and doing it effectively, so that we can influence the profession of medicine, influence healthcare for the better.
Yeah, those are definitely very prescient words that you've shared. As I think about resources, obviously, I think about you all have created a model program there at Duke. Also, I think that the group at Mayo with John Barlow and Chris Camp have designed an incredible leadership and professionalism track that is helpful. Maybe for those individuals that are early to mid-career surgeons and they want to become better leaders, what additional resources might you recommend to them?
Yeah, I think there's lots of things out there, and number one, if you're trying to build something at your own institution, figure out what your own secret sauce is. I mean, at Duke, we were very fortunate to partner with the business school, to partner with athletics and Coach K, to partner with some of our friends in the military, to partner with the School of Public Policy. So, you know, who we can work with and collaborate with, because I think that's an important piece of how you can be successful. And every institution is going to be different. I mean, at Wake Forest, you have some tremendous resources as well, and I've your medical students are really, I think, very committed to leadership education. I've spoken to them over there. And we have one of your residents in the Fagan Leadership Program right now, Amin. And so I think you can learn from each other, but you also have to understand, you have that's special that can really impact what you're trying to do at your place. As far as individual growth, I mean, there's books, there's tremendous leadership books. I could recommend tons. On our Fagan website, we have resources of books and articles about leadership development. There's videos. You have to figure out what aligns with what you're trying to do. The AOA has this Apex leadership program that helps people develop their leadership skills. I think that's another avenue within orthopedics, and certainly, the Shoulder and Elbow Society has a emerging leaders program that's now, I think, in its third year, and it's a great resource for early career members of the society. I don't like the term emerging leaders, so I'll publicly say that, because the people that are in the program are already leaders. In fact, all the members of Shoulder and Elbow Society, me included, we're all leaders, and we can all be better leaders if we take advantage of all those opportunities that are out there. And I'll put in a plug for what we're doing at AOSSM. Not only do we have a mentorship program that we've started, we have something called the BOLD program, Building Orthopedic Leaders Development, which is modeled after the Fagan Leadership Program. And instead of being a 9-month program, it's a 2-year program for early career members in the AOSS. So I think if you really want to develop your leadership skills, and I would encourage everybody to want to do that, there's a lot of resources out there to do it. It's not going to happen passively, though. And one of the great challenges that I see is as we try to help the future of medicine develop those leadership skills, I've learned that, especially for the students, if they don't want to, you can't teach leadership. You can only help people learn skills that will help them to be more effective leaders. I've had a lot of lessons learned where we try to create something for a wide audience, and on both ends, they're not interested. Either they think they're already effective leaders. Why do I need this? Or I'm never going to lead people. Why do I need this? And the truth is, you're always going to be working with others, and how you interact with others are important skills that'll prepare you for success no matter what you're doing.
Yeah, I'd commend you on the BOLD program. I have the benefit of being a mentor in that, and that's been incredibly helpful. And the leadership development program through the ASES, I also had the benefit of doing that, and I think you really learn a lot about yourself. So you've shared with me, and I'm still recovering, that you're officially retiring from clinical practice this year. What's next in store for Dean Taylor?
I don't know is the short answer. And that's not entirely true. I do know. I turned 65 in March, and there's a lot of other things that I want to do in terms of education. So it's a good time for me to kind of reflect on what's important. I feel like I've clinically done all the things that I wanted to do, and have trained over 60 fellows now. So, and we've got a great team here at Duke, so that I can hand off a lot of the clinical things to my partners, and feel good about where my patients are, and patients to come. Um, that said, I also want to really expand on what we're doing in terms of leadership education. Really expand what we're doing with the Reagan Leadership Program, what we're doing with the leadership education in the School of Medicine here, and expand that outside of Duke. So that's of interest to me, and looking at other opportunities that may be out there as well. So I'm not going anywhere. I'm not retiring. I'm stopping clinical practice on a regular basis, and looking forward to some new adventures along the way.
I look forward to benefiting from your next chapter. Any parting words of advice or wisdom for our listeners?
I would say that we talked a lot about our professional things, but I don't want the personal side to be slighted in this discussion either. Just remember, your most important thing is your family and your friends, and I've been blessed to have an amazing family. My wife Ann is incredible, and I wouldn't have been able to accomplish anything without her. And I've got two amazing adult children. Kate is an amazing writer for Business Insider. So if you want to look at anything she's written, just Google Kate Taylor Business Insider, and you'll learn a lot about the commercial industry and the intersection of business and the social world. And then my son Ben is and his wife April. They're both on the business side of things too, and Ben has been working in healthcare, and in the area of expanding the outpatient treatment opportunities for patients with opioid use disorder, with a company called Groups Recover Together. And now he's taking what he's learned from that, and he's going to apply it in a broader scale, I think, going forward. So I would say, family is and friends are where you're going to find your foundation for everything that you're going to do in your personal life, and intermingling those, I think, has been a good way for me to approach it, so that we can share both the personal and professional aspects of our lives in ways that are very meaningful in both worlds. So I guess That's how I'd leave it.
I think that's a very appropriate one. Please pass along my best to Anne and your family. I look forward to the time for when we can get together again. I think that's about all the time we have for this podcast. Thanks so much, Dean. Really, congratulations on your presidential year with AOSM. Many thanks for your continued mentorship throughout the years. And for all our shoulder and elbow listeners out there, don't forget to subscribe. And for Peter Chalmers, I'm Brian Waterman. We'll see you next time. Thank you.